Hello friends. So today we'll be discussing the second part of anticoagulants. So what did we discuss in the last class? We have seen how the coagulation pathway is working, how we classify anticoagulants into oral and parenteral, and we have seen in detail about parenteral anticoagulants, that is your indirect thrombin inhibitors and direct thrombin inhibitors. So now we'll see more about the oral anticoagulants, the uses, adverse effects, contraindications of these agents. So how do we classify oral anticoagulants? Oral anticoagulants, we have vitamin K inhibitors, under which comes warfarin, dicumarol, phenydione, and factor 10A inhibitors, that is zevaroxaban, apixaban, direct thrombin inhibitors like zimelgatran and dabigatran. Okay. So first we'll see vitamin K inhibitors, which includes warfarin, dicumarol, azenocumarin, phenydione. How does it act? It acts only in vivo. It interferes with post-translational GABA carboxylation of glutamic residues for factor 2, 7, 9 and 10. Okay, by inhibiting the enzyme vitamin K epoxide reductase. Is this sounding confusing? What does all this complicated sentence mean? Post-translational GABA carboxylation of glutamic residues. Basically, for certain clotting factors, that is 2, 7, 9 and 10, these clotting factors, they are synthesized in the liver. For their activation, they require this carboxylation, gamma carboxylation of the glutamic residues for activation of these factors. And for this step, that is for gamma carboxylation of these clotting factors, we require vitamin K epoxide reductase enzyme. And that enzyme is getting inhibited when you are giving warfarin. We'll see a picture to make it more clear. So you can see here, there are clotting factors here. Glutamic acid getting converted into gamma carboxy glutamic acid. So this is required for activation of clotting factors 2, 7, 9 and 10. Okay. So you can see here at this step, hydroquinone is getting converted into epoxide. This epoxide again is acted upon this vitamin K reductase to regenerate hydroquinone. Okay, so the regeneration of epoxide to hydroquinone requires vitamin K reductase enzyme, which is inhibited by warfarin. When this regeneration is not taking place, this gamma carboxyglutamic residues activation of these clotting factors is not taking place. That results in inhibition of these clotting factors. So, vitamin K dependent clotting factors are not activated. That is your factor 2, 7, 9 and 10. Okay. Factor 2 having the largest T-half of 60 hours and factor 7 as having a T-half of 6 hours. So, minimum 6 hours it takes for the action to happen. Okay, if we are giving vitamin K as an antidote for warfarin toxicity, it takes minimum 6 hours for the regeneration of factor 7. So, this is the reason why warfarin is given as a maintenance therapy, not for initiation therapy. If you remember our last class, how did heparin act? Heparin directly inhibits the activated factor, both factor 10 as well as factor 2. Whereas here, already activated factor is there. Okay. What does these warfarin do? It inhibits a further activation of these clotting factors. So, already activated factor will always be there. Only after it's eliminated from the body, the anticoagulant activity starts appearing. Other than this clotting factors, it also inhibits protein C as well as protein S activation. So, the whole effect takes 1 to 3 days for degradation of clotting factors. That is the reason why we use it for maintenance therapy. What is the pharmacokinetics? It is metabolized by CYP2C19. So, variations in this enzyme can have alteration in the metabolism of warfarin. Plus, warfarin is a drug with various or numerous drug interactions. Both enzyme inducers, inhibitors can alter the warfarin metabolism. It is highly protein bound. So what is the significance of knowing it is highly protein bound? If you are giving warfarin with another highly protein bound drug, like for example NSAIDs, what will happen? NSAID will displace the warfarin from its protein binding site so that the free warfarin levels increases. It is always the free drug that is active and that can lead to warfarin toxicity. Okay. Now it follows mixed order kinetics. What is meant by mixed order kinetics? At low doses it follows first order kinetics. High doses, when the metabolizing enzymes are saturated, it follows zero order kinetics. So that is why it is known as mixed order kinetics or saturation kinetics. So basically we are worried about a toxicity. When it crosses a certain plasma concentration, it can go in for toxicity. Now, if a pregnant woman takes warfarin, what happen? It can cross the placenta and can cause something known as fetal warfarin syndrome, otherwise known as Conradi syndrome. So that will manifest as growth retardation, stippled epiphysis, the hypoplasia of nose and hand bones, because of which it should not be given. But it is not secreted in milk, so can be used in lactating mothers. Now, warfarin mainly affects the extrinsic pathway, that is activation of the factor 7. So, we mainly monitor it by giving PT, and for a standardized value, we monitor the INR, PT-INR values. So, PT, because warfarin mainly affects the extrinsic pathway, to standardize the PT measurement internationally, we compare it with an international sensitivity index, which is expressed as international normalized ratio. So usually we adjust to give it to an INR of 2 to 4. Okay. And based on different clinical situations, like if the patient is having atrial fibrillation or having a prosthetic valve, the INR value differs. Clear? And what is the main adverse effect or what happens when there is overdose of warfarin? Any anticoagulant, bleeding is a side effect. Skin necrosis can happen, especially over breast, thighs, and buttocks. It can happen as early as 3 to 10 days after starting the therapy. How will you treat? If INR is less than 5 above the therapeutic range, you stop warfarin, restart later at lower doses. But if it is more than 5, in the range of 5 to 9, you have to give the specific candidate, that is vitamin K1, 1 milligram. If it is in the range of more than 9 but there is no bleeding, you give vitamin K1 itself, higher dose, that is 2 to 3 milligram oral. If it is more than 20 or there is bleeding, you have to give fresh frozen plasma to supplement the clotting factors. Okay. So what is the difference between the heparin and warfarin? Of course, in route you have difference. Heparin is given parenterally, that is subcutaneous or IV, whereas warfarin we give it oral. Onset, heparin is fast onset, whereas warfarin is delayed onset. What is the reason? Because heparin inactivates the already activated factor, that is 10 and 2A, whereas warfarin uh, inhibits the activation of clotting factor. So what that is the difference in mechanism of both the um, agents. So that is the reason why heparin is used for initiation, whereas warfarin is used for maintenance of therapy. And what is a specific antidote? Antidote for heparin is protamine sulfate, and antidote for warfarin is vitamin K1. Okay. And how do we monitor? Heparin we monitor by APTT, whereas warfarin we monitor by PT-INR. So these are the major differences between warfarin and heparin. And as I told, there are many drug interactions for warfarin. There are many factors that predisposes for this drug interaction because it is highly protein bound, plus it is metabolized by CYP2C9. Okay, so a drug enzyme inhibitors like erythromycin, ciprofloxacin can increase the concentration of warfarin and can lead to warfarin toxicity. Similarly, when you're using broad spectrum antibiotics, cefamandole, cefaperazone can also cause warfarin toxicity. Highly protein-bound drugs like aspirin and NSAIDs can displace warfarin from its protein binding site and can result in warfarin toxicity. Whereas if you're giving enzyme inducers like rifampicin, barbiturates, or griseofulvin, that can cause decrease in the warfarin and decrease therapeutic levels that can lead to therapeutic failure. Similarly, OCPs in pregnancy also the warfarin effect decreases. So this is the difference between heparin and warfarin. We have already discussed. Heparin affects the intrinsic pathway, warfarin affects the extrinsic pathway. Mechanism we have seen, route we have seen, teratogenicity, it causes Conradi syndrome, the warfarin causes Conradi syndrome. Onset, duration, warfarin is prolonged, slow onset, many drug interaction, elimination, heparin renally, warfarin hepatically, and regarding the monitoring and antidote. Now coming to the newer oral anticoagulants. So we have direct thrombin inhibitors, under which comes zimelangatran, which is withdrawn due to hepatotoxicity. But dabigatran is a prodrug that has been widely used these days, mainly used for prophylaxis of stroke and systemic embolism. Another idarucizumab is a monoclonal antibody against dabigatran, which we give for dabigatran toxicity. Now we come to factor 10A inhibitors that will come and directly inhibit the factor 10. Again, this is a newer anticoagulant under which comes apixaban, rivaroxaban, edoxaban, and betrixaban. You can see in all these names factor 10 activated will be there. Okay. So what does it do? It directly inhibits the factor 10 without acting on other agents. So it is preferred over warfarin in atrial fibrillation. Warfarin is mainly preferred in patients with mechanical prosthetic valves with advanced kidney disease, moderate to severe mitral stenosis, and who cannot afford the newer drugs which are quite expensive. Now next we come to uses of anticoagulants in general. Okay, both heparin as well as warfarin. So where do we give anticoagulants mainly? Where do we give antiplatelets mainly? We have seen antiplatelets have major role in arterial thrombosis, whereas anticoagulants have a major role in venous thrombosis. Okay, if you remember that, you will be knowing the uses. So basically for prevention as well as treatment of deep vein thrombosis as well as thromboembolism. So prophylaxis in case of bedridden, post-operative, or those with large leg fractures. In chronic atrial fibrillation, to prevent the thromboembolism, we give warfarin. Okay. Then unstable angina, you give an antiplatelet. Together with that, you give heparin. Okay, to prevent the occlusion. Then in coronary angioplasty also, we give heparin to prevent the reclotting. And it is also given for DIC, okay, disseminated intravascular coagulation, which is otherwise known as defibrillation syndrome. What are the contraindications of anticoagulants? It is simple. Wherever there is excessive bleeding, warfarin will be contraindicated, like bleeding disorders, peptic ulcer, hemorrhoids, severe hypertension, subacute bacterial endocarditis, ocular neurosurgical malignancies where there is a risk of bleeding. So with that, we come to the end of anticoagulants. So basically, you should know the coagulation pathway, the classification of anticoagulants, parenteral anticoagulants, heparin, how does it act, what are the uses, adverse effects of heparin, oral anticoagulants, remember everything about warfarin, a bit examples and where it is used about the newer anticoagulants like direct 10 inhibitors and direct thrombin inhibitors. Okay, and what are the adverse effects, contraindications, and uses in general. Okay, so hope you understood. Thank you for listening.